All right, so I think in the interest of time, I will go ahead and get us going. Thank you to all of the trainees that have joined as panelists, and welcome to the T&E Foundations Curriculum Lecture Series. We are happy to have all of you here, and our speaker for the month. This is our second talk for this academic year, and it promises to be a great one as always. So just some housekeeping things. For those of you who are the panelists, so the trainees, you are able to turn your camera on and turn your audio on in order to ask questions and interact if you would like. You don't have to. The lecture itself will be getting recorded. Once that lecture is done, we will stop the recording and have the question and answer session. And so at that time, feel free to put your camera on and take your audio off. If there are some interaction, if there's questions asked and things like that, feel free to answer those either in the chat box or by taking your microphone off and answering audio with your audio. For those of you that are participants, not the panelists, not the hemodynamics fellows, please put all of your questions into the Q&A box. The chat box does tend to get pretty full for us, so it's much easier for us to be able to follow those questions that are coming up and make sure that we've addressed them. If they're in the Q&A box, it should be right next to your chat box. I think that's the housekeeping stuff. So welcome, and let's get us started. So Dr. Luc Mertens is the echocardiography section head at the Hospital for Sick Children in Toronto, and a professor of pediatrics at the University of Toronto. He trained in pediatrics and pediatric cardiology at the University Hospitals Leuven and at the Mayo Clinic in Rochester. His clinical expertise is in pediatric echocardiography, and his research interests focus on studying cardiac function in children. Today, he'll be talking to us about essentially physiology. Lots of fun stuff to talk about. So welcome, and thank you so much for having this talk for us.
Thank you, Danielle, for the introduction. Try to share my screen. Oops.
Should be able to.
You see it?
Yes.
Oops. Now I have to change my display set. Huh.
Perfect.
So you see everything?
Yes.
Yes, it's working. That's always a very reassuring start. So I got a challenge of talking to you about physiology, and what I decided to focus on today is to talk a bit about the physiologic determinants of ventricular function, which is really key when you look at echocardiography and if you want to understand and interpret the data for clinical use. So a good understanding of this basic physiology is really essential for clinical practice. I have no disclosures for this talk. So what I'm hopefully going to be able to do with you is to give you some understanding of the physiologic determinants of ventricular function. I decided to focus entirely on systolic function because talking about diastolic function and filling of the heart is a completely different topic, and I only have 45 minutes. So I hope that you will have some understanding at the end on how those different factors affect the assessment of patients in neonatal hemodynamics, and in particular how you can interpret the echocardiographic parameters. And hopefully I can shed some light on why neonates are different and what's unique about their cardiac physiology. So we'll start with some cases. I will try to give you a theoretical framework which you can use on when you try to interpret cardiac systolic function. And hopefully it will give you some insight in some of the limitations current echocardiographic parameters have. I won't be able to go over all of them in detail because that would take too much time. So I'll give you a very classic example. This is a preterm baby, 25 weeks, very low birth weight, 560 grams. He had a PDA and 3 failed courses of medical therapy. Still had a PDA with left to right shunt. He's now 29 weeks and weighs 810 grams. So I don't have to explain to you that this is a PDA with exclusive left-right shunting. I will focus on ventricular function, and those are the images. The images you see kind of related to ventricular function. So I just have to get this thing out of my way. Yeah. Related to ventricular function, and typically those are the images we use. And for what you can immediately see when you just look by eyeballing is, first of all, and I will stress that's also always important when you try to assess function, the heart is big, the left, we focus on the left ventricle here. You see a dilated left ventricle, you see a dilated left atrium. Visually, you can immediately see that there seems to be qualitatively good ventricular function. We look in different directions because the heart is a 3-dimensional structure with a complex 3-dimensional fiber arrangement. And this is the reason why we look in different directions. In the short axis view, what you can nicely assess is typically radial and circumferential function. The circumferential fibers in the heart result in contraction that actually shorten and thicken the walls in a radial direction. Interestingly, in the ventricular wall in the left ventricle, there are no radially oriented fibers. But when we look at ventricular shortening and thickening, especially in a short axis view, what you look at is ventricular thickening of the individual walls. You can see here, when you look at this ventricle contracting, that the walls are nicely thickening across the different segments you can assess here in this short axis view. So here you assess mainly circumferential function because the largest amount of fibers in the left ventricle are circumferentially oriented. And when you look at the short axis, long axis view, the thickening in a radial direction represents mainly circumferential shortening. So here you have a dilated left ventricle with nice thickening of the ventricular walls, homogeneous across the different segments. There's no regional wall motion abnormalities. You can notice that some flattening of the interventricular septum suggesting some elevation in RV pressures. When you look at the apical 4-chamber view, you can see immediately again that the atrium is dilated, the ventricle is dilated, and you can see when you look from an apical view, is from a ventricular function perspective, you assess more the longitudinal function of the left ventricular contraction. Because what you can see here is the motion of the lateral wall, especially here the basal part of the LV wall, which moves down in a longitudinal direction. And this longitudinal motion of the LV is mainly caused by longitudinal fibers that are in the outer layers of the heart and the inner layers of the heart. The epicardium and endocardium of the heart consists of more longitudinally oriented fibers. So when you look at an apical 4-chamber view, what you see the downward movement of the base of the heart towards the apex, and the downward movement here of the ventricular septum from the base towards the apex. You see some inward motion as well. This inward motion and thickening of the walls is actually mainly caused again by the circumferential fibers, because this is exactly the radial function which you could observe from the long axis and the short axis views. So it's important to know that when you look at the heart in different cuts, you actually look at different parts and different fiber orientations. And that's why you have to combine different views to be able to assess global left ventricular function. So this is a way of assessing the pump, and you have to understand some of the basic physiology behind the different views to get some understanding of how function is affected in different pathological conditions. What we clinically use typically in cardiology in general, and that's whether it's pediatric cardiology or adult cardiology, one of the main parameters for expressing systolic function is ejection fraction. And which is a logical thing to look at, because if you think what is the main function of the heart is a pump. And what the ejection fraction represents very nicely is pump function. So it represents the percentage of blood that is pumped out of the ventricle after it ejects. You look at the volume of the ventricle when it fills, and you look at the volume of the ventricle at the end of ejection. As you calculate the percentage of blood that was injected by the pump. So ejection fraction is an excellent parameter for pump function. But I will explain to you during this talk that there are different parameters affecting your overall pump function, and that you cannot identify a parameter like ejection fraction with contractility, which is a very different parameter. LV strain is a parameter we use in echocardiography. Myocardial strain is deformation of the heart. And what we look at here, and this is strain in the longitudinal direction, is we look at how the myocardium deforms from end systolic to end diastole, from end diastole to end systole. In the longitudinal direction, this is shortening. In a radial direction, this is thickening. So because it's shortening in the longitudinal direction, it is typically expressed and by convention as a negative parameter. Here you look at what's happening with changes in systole within the myocardium. Again, those deformation parameters intrinsically are influenced also by loading conditions, as I will explain later, because this is intrinsic for any parameter we use in echocardiography. Now, the advantage of strain imaging is that you look directly within the myocardial wall. So you look at how the myocardium deforms, while if you look at ejection fraction, you look at the effect of this deformation on the ejection of blood into the circulation. So you look more at pump function. When you use strain imaging, you look more at the level of the myocardium, you look more at myocardial function. So you look at the degree of deformation within the myocardial wall in specific directions. You can use three-dimensional strain, but that gives you very complex parameters. So if you look at what happened, because this is an effect post-closure, you will see that compared to pre-closure, there are important changes. If I go back to the pre-closure left ventricle, you can see that my ejection fraction at that time is about 62%. This heart is hyperdynamic. And when I go post-duct closure, you see important changes, that the heart is less hyperdynamic. The ejection fraction I calculated definitely is much lower compared to what happened pre-duct closure. The only thing I changed is actually close the duct in the catheterization laboratory and remove this PDA from the circulation, remove it especially from the left side of the circulation. So what happened is a change in ejection fraction, in pump function, is also a reduction in strain values, because and I didn't include the images, pre-closure of the PDA, the strain was in the level of 17%. Post PDA closure, it was in a global longitudinal strain measurement was in around minus 15%. So what changed when I closed the heart, when I closed the PDA, when we closed the PDA in the cath lab? What changed at the level of myocardial function? Did the contractility change acutely? Did the heart become less contractile when I removed the PDA from the circulation. For sure, there was a volume change because we all know that PDA results in volume loading of the left ventricle. There also is a resistance change because when the pulmonary circulation is connected to the left ventricle through the PDA, that means that the left ventricle is pumping not only in the systemic circulation, which has a higher resistance, but also in the pulmonary circulation, which is a lower resistance. So if the pulmonary circulation is connected to the LV and I close the PDA, all of a sudden there is also a change in resistance the ventricle will sense when it tries to eject blood into the circulation. You may have noticed as well that there is a heart rate change, because the pre-duct closure, the heart rate, when we were performing the echo, was higher compared to post-duct closure. So this will also, and I will explain to you why, this may also affect the interpretation of function and some of the pump parameters you will assess when you measure ejection fraction. When you measure ejection fraction, you measure strain, you always have to take into the consideration that you never directly measure contractility. Another example I will give you here. This is a 2-day-old baby presenting with cardiogenic shock, in a clinical shock picture. And this is the first image we got. We got urgently called to perform the echo. First image we got was an image from the abdominal aorta. You can immediately see it's a very abnormal color flow Doppler pattern with very low velocities and indicating the low cardiac output. So this is the parasternal long axis view, and you see it's very different from the previous view and the previous images you saw. Here you see a very severely dysfunctional left ventricle, a septum that's going back and forward between the right ventricle. There's a very dilated and dysfunctional right ventricle. You see that here as well in the short axis view. And again, those are the images representing radial function, circumferential function of the heart. And you see both at the level of the right ventricle slightly better than the left ventricle, is probably the reason why the baby is still alive. And because you can see that the right ventricle pushes the septum over in systole to a severely dysfunctional left ventricle, generating output from the left ventricle. It's the right ventricle that generates output, because the left ventricle barely does anything, because you don't see any thickening in radial direction of the LV walls. So that's how you can look at those images and try to understand some of the physiology behind it. If you look at the apical four-chamber view, you don't need to be an echocardiographic genius to see that there is a significant problem here. First of all, the left ventricular cavity looks significantly underfilled, and that could be mainly related to this very dilated, hypertrophic, hypertensive RV, which interferes negatively with the underfilled left ventricle. But it's obvious that also in the longitudinal direction, when you look at motion of this left ventricle, it's severely reduced. Remember the images you got from the PDA baby, where you had this vigorous motion of the mitral annulus with downward motion and longitudinal shortening of the left ventricular lateral wall, and also to some degree of the interventricular septum, which shortens always a little bit less compared to the lateral wall. So you first, for longitudinal function, assess the lateral wall and look at how it moves down. Here you can see it's significantly reduced. When you look at mitral inflow, and I told you already that I wouldn't talk too much about diastolic function, but still I wanted to highlight you something, because what you notice here is something, and you have to put an electrocardiogram on to interpret those images as well, and those flow patterns as well. What you notice in this ventricle, and for the filling of the ventricle, first of all, it's very short. You see also that you have this prolonged, this is the mitral regurgitation, because there was some degree of mitral regurgitation you see here. So this is the time the ventricle spends in systole. This is the time the ventricle spends in diastole. And what you immediately notice here is that filling of this ventricle occurs very late. This is filling mainly during atrial contraction. And I'll try to explain you why this is. Because this ventricle is sensing something, tries to eject blood as long as possible, and tries to spend a lot of time in systole. So you try to prolong systole, but this comes at the expense of filling of the heart, diastolic filling. So this is this diastolic systolic interaction. And you can almost not talk about function of the heart in general without looking at this systolic diastolic linkage. Just giving you as an example, because I promised you I would not talk too much about filling. More views, and this patient, you can see when we look at the aortic arch, and you have to keep your mind open. And this is a patient with a severe coarctation of the aorta, presenting with severe biventricular dysfunction. I won't go into details on how we diagnosed the coarctation, but what happened, when we started treating the baby with prostaglandins, is that you can see you immediately get a bit more relaxation in this coarctation area with more antegrade flow, and slowly the baby recovered on prostaglandins. Severe dysfunction still when you give prostaglandins, and so we had to wait. And obviously we did some other treatments apart from just giving prostaglandins. And the baby clinically improved over the next couple of hours, underwent arch repair the next day, where we relieved the obstruction to the circulation. And you can see what happens when you do the arch repair. I'm sorry, that doesn't loop. That function improves. First thing you notice is that the left ventricle seems to fill better, so there's better filling of the left side of the heart, shifting the septum back over to its normal position. You definitely have some decrease in RV pressure. The RV looks less dilated, so you have more favorable and more normal ventricular interactions in this patients. You can already see in the short axis view and this long axis view that you have better longitudinal function and also better circumferential radial function of the heart, because that's what we look at to understand cardiac function and cardiac pump function. So what changed here when you acutely do these interventions of first of all opening the PDA but in relieving some of the obstruction at the arch level, because what happens when you give prostaglandins, it not only opens the duct, but very often relaxes the ductal tissue that is involved in the constriction and the posterior shell formation that is involved in coarctation formation. So what acutely changed in this heart? Does contractility acutely change? Is there an acute change at the level of contractile function? Definitely there was a significant change in size of the ventricle when we repaired the heart, because the LV filled better, and there was an important better filling of the left ventricle with a significant change in size of the left ventricle, which immediately will affect how much the ventricle can pump. If it can fill better, it can also pump more. And I'll come back to that, how that's explained in physiology. So the change in volume is related to the same change in size. There definitely was a significant change in loading on the ventricle. When you relieve the arch obstruction, the loading for the left ventricle acutely changes. So there is an acute loading change, and the load to the ventricle was that high prior to opening the PDA that actually the ventricle could not overcome the load and started to fail. There was also a significant difference in heart rate, which is an important parameter, because if in a baby, heart rate is an important determinant of cardiac output. In a baby, the heart is relatively small, so that means that filling by definition and how much you can fill a relatively small ventricle is going to be limited by a relatively small heart. So one of the mechanisms a baby can increase cardiac output, and the main mechanism for increasing cardiac output is increasing heart rate. So it should never be forgotten, because a baby cannot adjust to increased metabolic demands by increasing stroke volume as much as an adult can. So that's a very significant difference in neonatal physiology compared to physiology in larger kids and adults. So this is 3 days after the arch repair, and you can see there's a significant further change, increase in left ventricular volume. The left ventricle opens completely when you remove the ventricle, and also you can see there's already some remodeling, and now you can see there's also this important change in wall thickness. This very small ventricle, kind of, it looked very thin as well, all of a sudden becomes much bigger and becomes much thicker. You could almost not believe this is the same patient, but I guarantee you it is. But this is how you can see important changes within a couple of days, just related to changes in mainly loading conditions. So that's what I want to focus on, is those important determinants of cardiac function in general. Talk about contractile function, preload, afterload. I will try to give you a very clear definition of what that actually means. Importance of heart rate and the impact of heart rate on contractility, and the importance, especially in neonatal physiology, of those ventricular interactions. I already illustrated that to you, this very impressive interaction between the right ventricle and left ventricle in the patients with coarctation. The heart is a very ingenious organ, and if you think about kind of it at a molecular level, cardiac contraction and how we maintain ourselves alive is entirely built on those actin-myosin interactions at the myofiber, at the level of the myofiber, where this active force development occurs based on actin-myosin interactions. Now, if you think about the sarcomere shortens about 10%. So you have a 10% shortening, at 10 to 15% shortening at the level of the sarcomere. So actin-myosin interactions result in a 10 to 15% shortening at the level of the sarcomere. Now, how can this translate, this 10-15% translate in a 60-65% ejection fraction? You know, the myocardium as such only does 10% shortening, and this is due to the way the heart is built. You know, the engineering design of the myocardium results in this augmentation of 10-15% shortening at the actin-myosin level, at the sarcomeric level, into a 60-65% ejection fraction. That's it's called efficiency. And this is possible due to this, which I already alluded to, this complex three-dimensional organization, especially of the left ventricle, where fibers run into different directions. And so, due to the fact that you have 10-15% of shortening of fibers in three-dimensional directions, there's augmentation of this 10-50% shortening into 60-65% ejection fraction. So it's the engineering at the level of the myocardium and the fiber orientation that you can have this augmentation in cardiac efficiency. So that luckily the cardiac fibers don't have to shorten 60-65%, because that would require an enormous amount of energy. So it's an energy saving thing to transmit 10-15% of fiber shortening into 65% ejection fraction. So if you look at cardiac function, it's important to, because I started at the level of the myofiber and the sarcomere, that's where the actual force development and myofiber shortening occurs. Now, if you think about that myofiber sarcomere is integrated within a ventricular wall. And when we talk about cardiac physiology, it's important to think about the different levels of how you can look at cardiac function. Because I can look at cardiac function at the level of the myocyte and the myofiber. I can look at cardiac function at the level of the individual wall segments. Look at radial, regional myocardial function. When I look at myocardial wall motion, what I will look at is the fiber force development within that wall will be represented. The force development will be represented as wall stress. And what I will see as a result when the blood ejects from the heart is a certain wall deformation. So the force results in regional wall deformation. At the level of the global pump, at the level of the global organ, integrated organ, when I look at left ventricular function, what I will look at is the force that is generated within the fibers will result in pressure buildup within the cavity. And when the aortic valve opens, the pressure will exceed pressure in the aorta, and this pressure gradient will result in ejection from blood out of the ventricle as a result of the wall deformation. So the deformation within the wall segments will result in ventricular ejection at a certain pressure that is generated by fiber force development. So those concepts are important, and it's important also to think in different logics at different levels. So when I go back to force development, and you can study force development, and you can look at that in individual muscle strips. And this is kind of the result of actin-myosin interaction. Now, what's interesting in myocardial physiology is that force development actually occurs very shortly, normally in a myocardium. The force development, the active force development, when we look at isolated muscle strips, you isolate a muscle strip and you put it up in a tension chamber and you electrically activate the myocardium to contract. So what you see is that myocardial force development occurs relatively quickly. It's this typical pattern. And if you think about cardiac systole, the force development typically occurs within the first 1/3 of the systole. So the rest, you don't develop force anymore. You just shorten the fiber when you open because the only thing you need force development for is for opening the aortic valve. The rest will happen when the aortic valve opens, your walls will shorten and will eject blood out of the heart. So you can, and this is work that was done in Belgium by the group where I used to work before moving to Toronto, where you can integrate some of the physiology. This was done in animal models, where we can try to get from the intact organ by looking at geometry, looking at deformation, and have simultaneous pressure measurements. We can create models where you can actually calculate active force development within the myocardium. Obviously, it's not possible to do in patients, but we wanted to do that to understand physiology. So you can actually kind of model based on those measurements, active wall stress. And this is done in, you can look at active force development and active tension development within the heart as an integrated organ. And this is in a porcine model. And as you can see, this represents quite nicely what you would see in isolated muscle strip experiments. And that allows us to do some modifications and look at active force development within the myocardium under different conditions. Now, most important, and this is just a proof of concept that it works, when you give dopamine, it goes up. When you give esmolol, it goes down because it's a negative allotrope. When you're pacing, it goes up a little, and I'll come back to that. Now, what happens when you acutely increase loading? And this is again what happens to force development when you acutely increase loading to the heart. The heart is a very ingenious organ because what it tends to do, because the heart only can, as a certain maximal force, it can develop. So what it will do when you acutely increase afterload, and this is a model where you acutely increase afterload by creating putting a constrictor across the ascending aorta. So you constrict the ascending aorta a bit, so you increase afterload to the heart acutely. So what the heart tends to do is it tends to prolong contraction. And I already alluded to you in the coarctation case. This is what you see happening in the heart, is when you acutely increase afterload, you will try to prolong ejection. A good example is when you go to the gym and you try to lift a weight. When it's a light weight, it's easy to do that. You don't need a lot of force development to lift a very light weight. When the weight is getting heavier and heavier and it exceeds the maximal force you can develop by your muscle, what you will try to, you will slow down contraction and you will prolong it to try to overcome the load you impose on your muscle. The heart does exactly the same. So it will try to prolong contraction to overcome the load you impose on it, because there are load sensors within the sarcomeres. They sense the loading, and the response to this increased load sensing is that you will try to prolong contraction at the expense of the time you give for filling of the heart. So systole will prolong, diastole will shorten. When you chronically expose the heart, it's the same when you go to the gym every day. When you go to the gym every day, you will build more muscle. If you build more muscle, you can lift more weight. The heart exactly does the same, because that will increase the maximal force you can develop by chronic remodeling of the heart. You can increase the maximal force, but still when you load the heart, it will still prolong contraction. Because when you do weightlifting, you will see the weightlifters will never push at the same speed that they can a heavy weight than they can lift a light weight. They will be able to push a lightweight much faster, but for a heavy weight, they will still try to prolong contraction to be efficient. So again, as I illustrate, this is our patient with coarctation. You try to prolong contraction when you increase loading. So force development when chronically, and this is from isolated muscle strip experiments in patients with congenital heart disease. When you isolate fibers from pressure-loaded ventricles, you see that their maximal force development goes up. This is from chronic volume-loaded heart, where you see the maximal pressure that can develop doesn't go up. So this is the adaptation at the level of the myofiber. If you think about kind of what's happening within the heart when you load it, this is examples of patients with coarctation. I learned it from Liv Hadley, who was one of the pioneers of myocardial Doppler. You see, this is a normal aortic profile. As I mentioned to you, force development occurs within the first 1/3 of the cardiac cycle. So you see this velocity increase very early on in systole. When you increase kind of loading, when you have aortic stenosis, and the more severe it is, you see that the peak of this maximal flow velocity comes later on in systole. You also see that here this velocity rapidly decreases because force development disappears rapidly. Once you have the momentum of blood and you have the pressure within the ventricle, the blood just gets out of the ventricle by deformation of the wall. Resulting from the force you develop, and then you open the valve, and that results in the movement of blood forward. But when you have a aortic stenosis, you see that you have this continuous high velocity because you have to continuously build up the force to get the blood out of this narrowed valve. So this is this prolongation of force development you see in a loaded heart. So this is important to understand some of the things you observe in echocardiography. When we want to study contractility, it's almost impossible to do that without changing loading conditions. And you are familiar with pressure volume loops, and we won't get too much into the details of the concept of pressure volume loop. But what you do in pressure volume loops, basically, because you start from a baseline, which is this baseline, and what you do when you put in a conductance catheter, which can measure volume instantly, and you put a pressure catheter that measures pressure. So pressure volume, you have to measure volume, and you have to measure pressure. So this is a normal pressure volume at baseline. What happens because one volume loop gives me 1 point on this curve. What happens when I decrease preload, for instance, an IVC occlusion, is that I will decrease preload to the heart, and you will see immediately the changes in the pressure volume loops when I reduce volume to the heart will become smaller. And the lines of this end pressure volume loop relationship represent the contractility of the heart. So I cannot study contractility without changing loading, because end systolic pressure volume relationship represents kind of the contractility of the overall intact organ. obviously not of the intact myofibers. You can study this in patients who are doing pressure volume regulation, and it's been done in patients with congenital heart disease, and you can see contractility is acutely affected by going on cardiopulmonary bypass because it decreases very significantly after bypass. I'm not going for this purpose. I just want you to remember that studying contractility is impossible without taking loading into consideration. That the term contractility should be avoided when taking about echocardiographic evaluation, because you can only study it when you would study load changes, and none of the parameters directly represent contractility. So never speak about that you're able to assess contractility, because you're not. And my examples are good examples because acutely within the myocardium, contractility didn't change in my two examples. If you have a PDA, your myocardium doesn't become stronger or weaker. If you have an acute correctation, my heart muscle doesn't become stronger or weaker. There's no change in intrinsic contractility within the myocardium. The only thing that changes in both conditions is the loading you impose on the heart. So when you use echocardiographic parameters, you should never talk about contractility of the heart. What is assessed by most systolic parameters is actually pump function or myocardial function. Another point I want to make is the influence of heart rate. And heart rate is an important determinant of contractile function. And this is related to the fact that you're aware that contraction, and I won't go into basic physiology because it would take me too long, that the heart contraction is generated by calcium release from the sarcoplasmic reticulum. And there's a small calcium influx through to the cell membrane that results in calcium-induced calcium release from the sarcoplasmic reticulum. Now, when I increase heart rate, what happens with calcium cycling in a healthy, mature myocardium is that cycle accelerates. And what happens when you increase heart rate is that you actually are able to store more calcium within your sarcoplasmic reticulum and release it. So that results in this increased contractility when you increase cardiac heart rate because of cardiac cycling, calcium cycling. So there's an effect of heart rate on cardiac contractility intrinsically due to the calcium-induced calcium release and the acceleration of this process when you increase heart rate up to a certain limit, of course, because there's a certain limit in how much calcium you can actually store in the SR and how much you can release and pump back into the SR. Now, the difference of newborn versus infant is that in a newborn, that sarcoplasmic reticulum is very immature. A newborn baby is born with an immature sarcoplasmic reticulum. That means, and this is from experimental data, a very nice paper, 2009 in pediatric research, where they looked at force frequency relationship in newborn versus infant. Now, in a newborn, when you increase heart rate, this is nicely illustrated here. The only thing you do is increase heart rate in a newborn fiber strip. What you can see is that in a newborn, that's a flat line. When you increase heart rate, developed force doesn't increase. However, in an infant, so in an infant about one month old, what you need for maturation of the SR, so there's an important change there from newborn to infant. In a few weeks, you mature the sarcoplasmic reticulum. So you cannot look at a newborn and an infant in an identical way from a cardiac function perspective. They're very different because the myocardium matures rapidly within the first weeks of life. So in an infant, you have this capability of increasing contractility with increasing heart rate, which is one of the reasons why in congenital heart surgery, we try to avoid doing newborn surgery because your myocardium has much less functional reserve compared to an infant heart. So that's why we prefer to do cardiac surgery more around a couple of months of age rather than doing in the newborn period, because there's an effect of cardiopulmonary bypass that further depresses cardiac function. So you don't want to do that when the heart is especially vulnerable to those situations. It's important to realize the important difference. Force-frequency relationship can become very abnormal in disease situations, and this is just an example in adults where hypertensive cardiomyopathy results in decreased force-frequency relationship. It also can come abnormal in certain pediatric disorders, but I won't go into too much detail. So it's important to consider heart rate, especially when you get out of the newborn period. So when assessing systolic function, you should take it, and especially when you compare serially systolic function, heart rate is an important factor to take into consideration, with the exception of neonatal evaluation, where there's less impact of force-frequency relationship on cardiac function in general and contractility in general. Remember, however, that in newborns and neonates and infants, heart rate response is the main driver for increasing cardiac output, given the fact that LV and RV volumes are relatively small. So heart rate, contractility, I tried to explain, can the one factor we can not really measure by echocardiography. Heart rate is very easy to measure. You will have that in your images. Afterload is an important physiologic factor to take into consideration of everything we see in cardiology. Now, afterload is a term that's often confusing, and it is often misused. It is often mislabeled. You see a lot of publications where the term is used wrongly, because you have to remember that afterload comes from the 19th century, where they started doing this isolated muscle strip experiment. So you mount this muscle strip into this muscle strip chambers. You induce contractility by giving electric stimulus. And what you basically do is you make this muscle contract. And what you can do is change the length of this fiber before it contracts, that we call preload, because it's the load you impose before you contract. Or you can put some weight on this muscle. And the only thing I differ here, changes here, is the weight you put on the muscle. So this is 50 grams, this is 100 grams. So the muscle will sense that weight after it's that load, after it starts contraction. That's why they call it afterload. So it is the load you impose on the muscle after it starts contracting. So that's the physiologic meaning of the term afterload. So never use it anywhere else in the context of the load you impose on the muscle after it starts contracting. So what happens with peak contraction when you impose loading is that the peak shortening decreases. You can see the shortening increases, and also the velocity of shortening decreases. When I translate that into physiologic into intact organ terms, that means that your ejection fraction will decrease when you increase afterload, and also the speed, your ejection fraction strain, which is your total deformation, will decrease, and also the speed at which it occurs, which is your strain rate, for instance. So kind of the force opposing shortening encountered after the onset of contraction. When I look at the level of the wall, afterload is defined as wall stress, because the wall will send kind of the intrinsic myocardial forces it develops, but also the forces surrounding it. And that's actually the afterload. So an acute increase in afterload, for instance, I gave you the example of constriction of the aorta, and an acute increase in blood pressure is another good example of an acute increase of afterload to the ventricle. Because when I acutely increase the aortic pressure, that means that the ventricle will sense a higher load after it starts contracting. So that's what I mean by afterload. Chronic increases in blood pressure, for instance, will result, because the myocardium, as I already showed you, as an intrinsic property to be able to adapt to chronic loading conditions. So a chronic loading condition, change in loading condition, if my blood pressure remains high for a long time, if I impose a bending on the pulmonary artery on the aorta, this will result in an hypertrophic result, in an hypertrophic response, which may actually normalize wall stress. Because when I thicken the muscle, the wall stress will decrease. So that's why you cannot identify pressure loading with afterload. It's a mistake that is often made, that people say blood pressure is high, so that means that my heart senses an increased afterload. That's nonsense, because you don't know that. Because it will be dependent how long that blood pressure has been increased and whether the heart has adjusted to that by chronic remodeling. So that's why loading conditions should only be used, and changes in loading conditions should mainly be looked at in the acute setting, when you're talking about acute changes in afterload or acute changes in preload. Chronic changes, the heart will adapt to that. Acute changes, the heart will adapt to that by using different mechanisms. Like for afterload increase, you will prolong contraction instead of generating more force. I hope you realize that it's an important distinction to make when you talk about physiology and cardiac physiology. So at a certain point, this baby is not going to be able to lift the load because it cannot generate enough force. At that level, the heart will fail. And this was illustrated by the coarctation case, where the load imposed on the ventricle was so high that the ventricle was not able to push the blood out of the ventricle. So that results in acute ventricular failure. We can study that. This is something we used to use when we did PA bending in our institution. We can use pressure volume loops, and we can actually identify the level where the ventricles start failing. Important is to remember that afterload is identified by wall stress. Wall stress is defined by pressure within the ventricle. So when you think that blood pressure reflects afterload, this is not exactly correct, because at the wall level, it is also not only determined by pressure, it is determined by radius of curvature. So if you have a flatter wall, the radius of curvature is bigger. If you have a more rounded wall, the radius of curvature is smaller. Even within the ventricle, wall stress is different at different levels, because the base of the heart has a flatter wall, so has higher wall stress. The apex of the heart it's more rounded, so it's lower radius of curvature, so has lower wall stress. And this is when you look at normal cardiac contraction, you see more thinning at the level of the apex compared to the base, because the wall stress at the apex is lower compared to the base. So you will have more effect of ejection at the apex compared to the base of the heart, which is hemodynamically favorable, because that creates momentum from the apex in the direction of the outflow, especially of the left ventricle. Another way of, you have to take into consideration, a wall thickness is an important parameter. And in the formula, this is the Laplace formula, it's 2 times the wall thickness. So wall thickness has relative more impact on wall stress deformation and definition of afterload. So if your wall thickens, that quickly results in a reduction of wall stress and in afterload conditions. So that's something you really have to remember. Also means that if the heart gets more spherical, it's not only a change in preload you're observing, but you're also observing a change in afterload. Because if you get more spherical, you actually change the afterload to the ventricle by changing the geometry of the walls. As I already mentioned, walls get also thinner sometimes when the heart starts dilating, which further results in increase in afterload. That's why afterload reduction in dilated cardiomyopathy actually works, because it reduces really afterload at fiber level. Something the heart also does, it changes shape when you acutely load the heart. And a good example is pulmonary hypertension or a pulmonary embolism in an adult, where you acutely change afterload to the right ventricle. That will acutely result in acute dilatation, resulting in an acute volume change of the heart, which will help for ejecting blood, because if you have more volume, you can eject more at the expense of increasing afterload. So I already mentioned kind of there's this different regional difference between the different levels of the heart. And this is, for instance, why you see more changes. This is a hypertensive adult patient, where that's why it's in the adult orientation, where you see more changes in the base of the heart, because that's where the effect of the blood pressure is sensed more. That's also the reason why in hypertrophic cardiomyopathy you see more effect of the in the base of the septum, because there again, that's the flattest wall within the heart where the afterload is the highest. When you develop hypertrophy, this definitely you can develop more force, but that goes at the expense of making your heart stiffer. And we all know that when you have hypertrophic hearts, that they tend to be stiffer. So that goes against at the expense, and this is some of the physiologic data, that goes at the expense of reduced filling of the heart. So when you remodel, and I already alluded to that, kind of you don't only change the volume of the heart, you also change the afterload, the ventricle senses. I'm almost there, because we all have to explain a few different concepts before I can open this for discussion. Preload is another important component to take into mind when you look at cardiac physiology, when you interpret cardiac parameters. Preload, as again, comes from this isolated muscle strips. And when you think about this isolated muscle strip, the preload is actually just the pre-contraction muscle length, because I can lengthening kind of this muscle a bit more, can shorten it a bit before I allow it to contract. So this is basically preload, because this is the change I make before I actually got this, the load I impose on the myocardium before I make it contract. So what we know from physiologic experiments is that if I lengthen the myocardium a bit more, that it actually results in more contraction. So, and that's related to a better interaction, optimizing the actin-myosin interaction at the level of the sarcomere. So you can optimize function by filling it more. So that means that kind of your contractile function is going to be influenced by my preload, my pre-contraction length. The difficulty with preload is that you cannot measure it in vivo. Very difficult to do, to know how long the fiber is before I contract it. So when I look at intact organ, I have to make some assumptions on what represents filling of the heart. And we can use end diastolic volume, for instance, as a surrogate for preload at the intact organ. Or sometimes in intensive care, we use end diastolic pressure when we measure CVP or capillary wedge pressures for the left side. We can use EDP as a surrogate, or filling pressures as a surrogate, which obviously is an assumption you make, because that's going to be influenced by ventricular compliance and does not directly represent my end diastolic or my preload contraction muscle. Because the stiffer my myocardium gets, the higher the EDP for the same volume. So that doesn't work completely. Again, when you have an increase acutely in end diastolic volume, or volume you put into the heart, you can speak about an acute increase in preload. Because if you fill the heart more, then you will have an acute increase in preload. Now, again, when it's chronic, when you have a shunt, like for instance a PDA, can you say that the heart is chronically works at increased preload? No, obviously you cannot, because the heart remodels and becomes bigger to accommodate the extra volume. So when you have eccentric remodeling of the heart dilates, and you actually can normalize preload. Because if you talk about volume loading of a bigger heart, it may be that preload, which is going to be determined by your end diastolic pressure volume relationship, is actually going to be normalized. So you can not again identify preload with chronic volume load. So you have to distinguish these terms. And there's, again, unfortunately in literature, there's this mixture of terminology from individual fiber levels to the intact organ, which you have to be very careful when you do that, and you have to define terminology very carefully. So we know that's the Frank-Starling relationship. When you look at the intact organ, when you increase filling of the heart, it contracts better. Again, contractile function is not load independent. because it will be determined by how well you fill the heart and how much afterload you impose of the heart. So, as I mentioned, dilatation of the heart can normalize filling pressure, but again, when you dilate the heart, this goes often at the expense of an increase in systolic wall stress, goes at the expense of an increase in afterload. Normal contraction patterns, normal electrical activation is essential for good cardiac function. And when you have left bundle backpack, right bundle backpack, that can result in dysynchrony, resulting in inefficiencies in systolic function. But I won't go further into this, because it can be applied to patients with congenital hearts. For neonatal hemodynamics, it's not that relevant. One final remark I would like to make on ventricular-ventricular interaction and myocardial crosstalk, because the two ventricles, when you have biventricular heart, luckily for your patients, in the majority of cases, it's a biventricular heart, but you have to take into consideration that those two ventricles crosstalk, because they have fibers, especially the outer layer of the heart, there are continuous fibers between the LV and the RV, and the interventricular septum is an important area where interaction occurs between the two ventricles. This is a very ingenious experiment where they electrically isolated the left ventricle from the right ventricle in animal model of cardiac function. So they could pace the left ventricle without activating the right ventricle, and they can pace the right ventricle without activating the left ventricle. So you can look at how those two ventricles crosstalk. And this is an example where you develop LV pressure with LV pacing in an electrically isolated RV. You can see when you do LV pacing, when the RV is not contracting, you actually build up pressure in the RV. And this is related to, if you don't build up pressure in the RV, the LV septum will bulge out into the RV and will push blood out of the right ventricle by generating pressure within the RV. So there's this crosstalk between the two ventricles. The opposite is true for pressure development within the RV. And my coarctation patient was a good example of that, because the reason why this baby was alive was entirely because of RV function, because the LV was not doing anything. Because the RV is more developed, because the RV does more work during fetal life, so it's relatively hypertrophied, and this RV could overcome some of because there was suprasystemic pulmonary hypertension, so it could overcome some of the resistances in the systemic circulation. So this is this crosstalk between LV and RV. So this is how the LV can contribute to PA, pulmonary arterial flow, which is see when you isolate the heart, it is quite significant how much output you can generate by just contracting the LV. This systolic diastolic interaction becomes extremely important in patients with pulmonary hypertension. For instance, you're treating in the NICU, where you have to understand how kind of pressure buildup within the RV interacts with pressure buildup within the LV, and how filling of the LV is influenced by dilatation of the RV. So this crosstalk between the two ventricles is very important in understanding cardiac physiology, especially newborns with pulmonary hypertension. So I'd like to conclude again, for factors influencing cardiac pump function, definitely intrinsic myocardial force development, the strength of your myocardium, the influence of loading, the afterload and preload, but please use those terminologies correctly. And think always about heart rate, and for some of your patients, ventricular interactions are very important to take into account. I hope the take-home message for this is that you don't use and abuse the term contractility, because it cannot be assessed without taking loading conditions and heart rate into consideration. And in no echocardiographic parameter directly reflects our contractility. I hope this shed some light on some basic concepts in cardiac physiology, and hopefully this is useful when you talk further about neonatal hemodynamics. Thank you for your attention.